regarding today's topic. I encourage you all to ask your questions in the chat box that is available, and we'll be taking it after the presentation. And after the presentation and question answer sessions are done, we'll be sharing you a link to submit the feedback regarding today's webinar, which will be helpful for you to get the e-certificate of participation as well. So I welcome Dr. Rajesh Vishwanath sir for today's presentation. You're welcome, sir. A brief introduction regarding Dr. Rajesh is, sir completed his MBBS from Gandhi Medical College, Hyderabad, and finished MS in Orthopaedics from Osmania Medical College. He went on to complete his fellowship in joint replacement from Germany and a fellowship in arthroscopy from Manipal University. Sir has been practicing since 10 years and is a senior joint replacement and arthroscopic surgeon in Warangal now. He's a consultant arthroscopic surgeon at Ajara Hospital and Veena Medicare. Welcome, sir. Now over to you.
Yeah. Good evening, everybody. Today, my talk would be on the role of arthroscopy in joint problems. So, basically, coming to the talk, here we should understand what is arthroscope first. Arthroscope is a small rigid telescope, and it is fitted with a fiber optic illumination. It is a lens system which ranges in diameter from 2 mm to 4 mm and a length of about 9 centimeters, and with an angulation of about 30 degrees to 0 degrees to 90 degrees of scope. And a basic arthroscopy setup consists of a light source, camera, shaver system, fiber optic cable, radio frequency ablators, a saline stand which helps us to expand the joint where we are going to examine or operate the joint. And there are small special instruments like punches, probes, different types of basket forceps, cannulas. So all this instrumentation system is put in something known as a trolley. So whenever we are doing an arthroscope, this scope is connected to a fiber optic cable, which is again connected to a video, which modifies into a digital signal, and we see the joint in a TV system, that is a LED kind of a surgical grade monitor. And as you can see in these racks, it consists of various instruments. This is a shaver system, light source, there is a printer, video recorder, and there is radio frequency ablator over here. And on the right side, there are special small instruments, that is forceps, punches, graspers, special instruments known as suction pumps, arthroscopy plates. This is an arthroscope which is connected to a fiber optic cable, and these are the shaver systems and attached burrs and shaver knives. So all this complex instrumentation system, which is which helps in the good visualization of the joint, is very important when we are doing an arthroscopy surgery. Nowadays, most of the joints, when it comes to the chronic joint pathologies, which are not relieved by basic medications, right from shoulder joint to knee joint, elbow, hip, ankle, as well as wrist, and nowadays even spine endoscopic surgeries are also being done. We should understand what is the advantage, why this arthroscopy procedure has evolved, and what are the advantages. When arthroscopy procedures were not there, most of the joint used to be opened completely, and most of the surgical procedures used to be done like that. And it is to have its own complications. Whereas when the arthroscopy procedures have evolved over the past 20 years, this has got many advantages, like it is minimally invasive procedure where only I can say only a 2 mm of joint, a hole is made into the joint, and it gives a complete detailed visualization of the joint, which is not possible in open procedures. We can go to every hook and corner of the joint, examine the joint very well, and we can even take biopsies, especially in case of infections. or inflammatory pathologies like villonodular synovitis or rheumatoid arthritis, we can not only take the biopsies and find out what is the real disease going on within the joint, but we can also do the procedure there, like a therapeutic procedure, so that most of the disease comes down. And the advantage of this is no blood loss. Absolutely, there is no blood loss, as most of the joint is not open. We don't cut any vessels or anything over there, so there is no blood loss. And the patient recovery is very fast, and the improvement in shoulder function or knee function is drastic, as well as there is less post-operative pain to the patient. So overall, it is a minimally invasive, highly advanced, which not only helps in visualization of the joint very well, but it actually magnifies the uh, joint structures that we see inside, with least complications of infection or blood loss, and faster recovery, and good range of motion of the joint is possible. Nowadays, most of the joints are treated by help of an arthroscopy, and as the digitalization has evolved from the TVs to now OLED TVs are also available. In the same way, in arthroscopy also, because of increase in the technology, most of the joints now can be visualized by means of an arthroscope. Initially, there was only one started from knee joint. Now we are able to see up to even metatarsophalangeal joints also. So most of the technology, it is a technology-driven science in orthopedics, and as the technology evolves, so the scopy, the visualization, everything is evolving. Now I want to give a brief idea about how arthroscopy is important to us based on the few basic pathologies that we see very frequently during our day-to-day practice, as well as specifically to few joints. I start this joint with a shoulder joint. You all know that shoulder joint is a ball and socket joint, and most often not every people, most of the people are affected by shoulder pains. So what we see in shoulder problems can be broadly classified into the following types. That is rotator cuff tears, dislocations or subluxations. There is something known as biceps tendon and its related problems. There is a labrum which gives support to the humeral head inside the shoulder joint, which we call it as a labrum. And in that we have something known as superior labral anterior posterior lesions, anterior inferior labral lesions that we know as Bankart lesions. There is impingement syndromes between the acromion and the cuff tendons, and there is ACJ, acromioclavicular joint arthritis, and osteoarthritis of the shoulder joint. So in all these problems, a shoulder arthroscopy can be an important tool, not only to diagnose, but also treat the conditions. And also one thing, very important thing that I want to stress here is infections. Even the infections, chronic infections, can be very well be cured by arthroscopy. As we do a saline wash, most of the infections can be washed off. We can take a biopsy, we can give some antibiotic direct dosage inside the joint, and we can help in the control of the joint infections. Now coming to the shoulder arthroscopy that I see during my practice, I am presenting few case scenarios in shoulder arthroscopy. So it is a case scenario number one, where a patient comes to me, 25 years old. He is a basketball player, and he got an injury to his right shoulder about 2 years ago, and since then he has episodes of shoulder dislocation on and off. And when I've examined his joint, he is having painful shoulder movements with very difficult in abduction and external rotation of his shoulder. And if he is instability, whenever he is trying to throw the ball into the basket, and he has stopped playing the matches or enjoying the game since few months. And on examination, when we do orthopedic examination, there is specific test known as apprehension test, where it was very much positive. Like when I abduct and try to externally rotate the shoulder, his shoulder joint is, his shoulder head is coming out of the socket. So that is an important clinical sign that we see. And when I got an X-ray, there is a Hill-Sachs lesion over there. and a MRI shows anterior inferior labral tear. So he has been around for 2 years, and initial episode, usually it is reduced under general anesthesia. And in spite of all the physiotherapy and medications, there was no improvement. So finally, when we see his picture, something like this. There is in the X-ray you can see that there is a small, even few cases we see bony fragments also during in the X-rays. And here is the Hill-Sachs lesion that a doctor sees during the X-rays. And this is a representation of what is labral tear inside. It is a very important tissue here, the capsule, to keep the head within the shoulder joint. And it is demonstrated here, where this is a capsule. It is attached to the bone by means of a labrum. When the labrum is torn like this, the head comes out, and that is known as a dislocation. We identify it by means of a labral tear. Previously, when these shoulder dislocations were treated by open method, so it used to use something like this. It used to look something like this, where an incision was given, lot of blood loss was there, identification of specific structure is very difficult, and there is a lot of pain, and post-op rehabilitation took very long time, more than years it used to took for rehabilitation. But now, with the help of an arthroscopy by keyhole procedure, we can go inside the joint, watch everything very carefully, very diligently. We are able to pinpoint each and every anatomy very well, elevate the labrum, loosen labrum, identify it, put some anchors. There are special instruments, anchors, arthroscopic specific implants known as anchors, which has a thread like this. And with special instruments, we tie this labrum back to the joint. And in this way, with cosmetic, it is very much cosmetic procedure, hardly any scar is seen, and the patient rehabilitation protocol goes on very well. So this is one example how arthroscopy is very much helpful for shoulder dislocations. And second example, it is a case scenario number 2, where a 65 years old lady has a trivial fall, slip over her shoulder. Since then, she has a disturbed sleep during her in the night, where she is unable to sleep well, and she is having problem to lift her shoulders. So X-ray was done elsewhere, and it has not shown any fracture. But on clinical examination, we have specific tests known as, when we test the strength of the muscle, it was found out that her upward movement, that is her abduction of the shoulder, was very weak. And a MRI was done, we showed a cuff tear, that is supraspinatus tendon tear, and a arthroscopy repair was to be done. So here you can see that in MRI, a doctor visualizes the supraspinatus tendon tear like this. So if we see an X-ray, everything is fine, no problem. These patients, generally we advise painkillers, ice packs, rest to them for 3 weeks, then we start rehabilitation, say for 1 month. And a patient comes back again saying that, doctor, there is relief of pain, but there is no improvement in, no gain in movements. Then what we generally do is we advise patients for an MRI scan, or nowadays in few centers, ultrasound scan is also done to identify the supraspinatus tendon tear. And after identifying the tear, she was advised, these patients are usually advised for a fixation, because if we don't fix the supraspinatus tendon, there is irreversible loss of shoulder movements. There will be weakness with the shoulder muscles. If you see the shoulder, the surrounding muscles are atrophied, and when compared to the normal shoulder, it looks very thin, and the strength in the shoulder is very less. So generally we advise for an rotator cuff repair. Previously it used to be done open. Now with the help of an arthroscopy with special cannulas and anchors, as you can see here, it is a torn tendon which has retracted. Now, one very important point is, the more time we take to repair the shoulders, the more retraction of tendon will be there, and there comes a point where we cannot repair the tendon also. So if such problems are there, you should consult an orthopedic surgeon, take his opinion, and go for such examination and images to find out if there is more problem into the shoulder. So by identifying such tears, we help with the help of a special anchors. So these are the special anchors, and finally this has been sutured back to the bone bed, that is greater tuberosity. And in this way, as you can see, these are special cannulas, these are special threads. Without opening the joint, by watching everything on the screen, we are able to dexterous our hand, and we are able to repair the shoulder, something like this. Okay. Now, next joint that I want to discuss is the other problems in the shoulder that we see is a adhesive capsulitis that we see in usually diabetic patients. Initially, it can be improved with the help of medications and physiotherapy. And once the shoulder movement is restricted, say to 20 or 30 degrees, say after 3 or 4 months of continuous physiotherapy, medications and exercises, if there is no improvement, then arthroscopy is the better treatment of choice to go there and remove the capsule. Now, the next joint that I want to discuss is a very interesting joint. Most of the people have problem in those in young age and old age, irrespective of the age. That is a knee joint. Knee joint is a most common joint that we see in our OPDs regularly. Most of the people will have a knee pain because of the following reasons. As we all know, osteoarthritis is the #1 cause. And in youngsters, it is mainly because of meniscus tears. Even articular injuries, like youngsters falling down from the bike can have an articular injury which cannot be diagnosed on an X-ray. And there can be a ligament tears known as anterior cruciate ligament tears, posterior cruciate ligament tears. So all these tears happen in the youngsters, and it can cause chronic knee pain with effusion, locking, inability to walk, not able to flex their knees. So all these problems, when we see and think, yes, we think that something is not good inside his knee joint. And when it comes to certain age groups, like middle age group to elderly age group, there are some conditions causing arthritis, formation of loose bodies, and because they don't move their knees, it may cause adhesion within the joint. And sometimes most of these joints, when people come from villages, most of these irritants are applied. All kinds of ointments are applied, and this can cause infection also. And the infections and all these problems can cause a knee pain. So what you see on the right side is a basic arthroscopy instrumentation. This is a scope a surgeon is holding into the other hand, and with the help of this arthroscope, everything can be seen what is happening inside the knee joint. So I would present a few case scenarios in the knee where we usually come across. So it is a case scenario number 3 concerned with the knee joint. A 23 years old patient who is a footballer. He had a twisting injury 6 months back, and he has gone for a treatment. X-ray was done, fine, normal, but he is having a recurrent complaint of instability, locking, effusion, pain. He's unable to dance. He's unable to climb down the stairs, and there is a difficulty in his pivoting activities, like sudden turn. When he's taking any sudden turns, his knee joint suddenly gives away. So all these problems he has come, and we, as an orthopedic surgeons, we do certain tests known as Lastman test and anterior drawer test, where we look for the stability of the anterior cruciate ligament. And when a MRI was done, it has showed his ACL tear over here and meniscus tear. So with the help of an arthroscope, you can see that here we will be able. So what does a arthroscope? Even previously open techniques were done for ACL, but an arthroscopy not only gives a good visualization of the anatomy inside the knee joint, where certain some tunnels has to be done into the knee and into the femur and tibia bone. This accuracy of finding the anatomical tunnels is only possible by means of an arthroscope only. So we will be able to identify these tunnels and mimic the natural anatomy as much as possible, giving an isometric ACL reconstruction with the help of an hamstring tendons. And on the extreme right, you can see that there are certain tears of his meniscus which can be repaired very well. This is a diagrammatic representation where it has been shown that the meniscus also nowadays are being repaired in youngsters. And also this is an arthroscopy picture. Before you can see the tear over here, and after the tear has been repaired. Nowadays, the world is shifting towards repair of meniscus. Unlike about 5 years back when meniscectomy used to be done very much commonly, but because of late increase in the arthritis and decrease in the shock absorbing capacity of the knee joint, nowadays we are preferring more meniscal repairs. So that and increase in technology of the meniscus repairing implants also, these repairs have become one of the preferred treatments of choice nowadays to prevent early arthritis, especially in youngsters. So these symptoms like locking, instability should not be neglected. They has to now the technology has grown such that these also can be managed very comfortably and easily with the help of an arthroscope. Now, this is another case scenario where a elderly age group, middle age group lady comes with 45 years old lady comes with chief complaint of sudden onset of pain, locking, effusion. On examination, we find crepitus, that is a abnormal sounds coming from the knee joint, which is tender, and this has even restricted her knee ROM. And when X-ray was done, it has showed early osteoarthritis with loose bodies. So we should understand what is this loose bodies. Loose bodies is nothing but anything floating inside the knee joint, whether it is cartilage, bone debris, or soft tissues, which cause any inhibition in the smooth gliding of the joint, that we known as a loose bodies. Most of these loose bodies, if it is filled with a calcium, we will be able to see in a X-ray, whereas cartilaginous loose bodies cannot be seen. In such case, we plan arthroscopy not only to visualize how is the knee joint inside, but also to remove these loose bodies, and it causes significant improvement in pain and knee function for this particular patient. As you can see here, usually if you go to a doctor, if they take an X-ray, when they show something like that, it's nothing but a loose body inside the joint. And there is no way that this loose body can come outside the joint because there is no outlet for the knee joint. So this loose body stays in, cause more damages to the joint. That is, it acts like a wind viper shield, wind viper effect, and it will take away all the cartilage of the knee joint, and in no time the knee joint will become arthritic. I have seen cases in my practice where I have advised a knee arthroscopy procedure for a patient who did not turn up, who turns up after say 3 or 4 years with complete degeneration of a joint. A stage comes where we can protect the joint from arthritis, but when the time is gone, then it usually lands up in knee replacement. So these loose bodies, as when we see into the joint, it appears like this, and with a special grasper and forceps, we remove these loose bodies, we debride the joint, and usually the patient does very well after the knee arthroscopy. This is a specific indication in osteoarthritis, where an arthroscopy is extremely beneficial technology to clear and to clean and to remove any debris and to lavage the knee joint with saline to prevent any frequent attacks of locking of the joint and early degeneration of the joint. Now our third joint that I am very much interested in to discuss is elbow arthroscopy. So generally what elbow arthroscopy, the indications are loose body removal, osteophyte debridement. There is synovectomy in case of any infections. There is elbow stiffness. Patient comes with elbow stiffness, sir, I am unable to move my elbow joint. So in these cases also, arthroscopy is a very important tool. Then there is something known as osteochondritis dissecans of the capitulum, where because of decreased blood supply into some part of the cartilage is worn out and causes pain. And there is most common condition known as tennis elbow or lateral epicondylitis, where there is pain in the outside of the elbow. Most of the people will suffer from this pain. It is usually seen in patients, in laborers, and septic arthritis. So these are certain things that I want to show you where we mark certain important portals on the elbow joint. Instead of removing or opening the elbow joint completely, we mark certain small holes over the joint and we examine the shoulder joint. This is one case scenario. Most common case scenario that I see in my practice is a case of something like this, known as a tennis elbow. Usually patients are in their middle aged, and most commonly there are female patients are very common. and they usually suffer from diabetes or uric acid problems, or sometimes a thyroid. And generally these are homemakers, and usually they work as part-time in the fields, agricultural fields, or as a tailors, or manual laborers, where they lift heavy things, and they develop pain into the elbow joint. One of these patients, she has already undergone a physiotherapy, and usually orthopedic surgeons, we give a shot of steroid also, something like injections to relieve pain, but it was not relieved. And she had tenderness in her lateral epicondyle, that is a lateral part of the elbow, and finally it was diagnosed as a lateral epicondylopathy. And X-ray usually done will not show any positive signs usually, and MRI shows a specific muscle is involved in this, that is extensor group of muscles, that is extensor digitorum brevis is the most common tendon that is involved, but as it is inserted just as the elbow capsule, it causes a lot of pain, and elbow arthroscopy was done in this case. So as you can see here, MRI is there where we identify the problem in her tendon over here, and by open method you can see that it is we cannot pinpoint the lesion here. What we go is we remove the degenerated tendon completely. Okay, and arthroscopy is a keyhole procedure where we identify the lesion here by help of a needle over here. You can see the needle. You can see the needle here. This is the exact pathology that we can see 100% in the arthroscopy, and that complete area is removed with a very good cosmetic effect. All the carpi radialis brevis is a specific tendon that is completely removed along with the capsule. So after this removal, the patient will have very good relief for a very long time. So arthroscopy is such an important tool for elbow pains too. Now, something to do with ankle arthroscopy also, it is a very important. So where it is indicated in ankle arthroscopy, there is persistent post-traumatic pain following conservative management, because there are certain conditions like loose bodies, post-traumatic arthritis, osteochondral loose bodies inside the ankle joint, and there is specific conditions known as retrocalcaneal bursitis or Haglund's disease, and here in Telugu we call it as Guraputulu. So something in this case I'm going to discuss with you. So this is a case scenario 6 where usually we see farmers because they tend to walk very much in their fields. Their tendo Achilles is always under stress. So this particular patient had pain in his retrocalcaneal region since 1 year. He's a smoker, alcoholic, and diabetic. He has consulted various doctors and there is no relief in his pain. He has used even irritants, that is local treatment to control the pain. When the patient comes to us, orthopedic surgeons, we take an X-ray and usually we find spurs. On clinical examination, we find there is swelling over his heel, and usually it is identified as an Haglund's disease. What actually happens in these patients is there is a normal calcaneum, something looks like this, whereas in Haglund's deformity there is extra growth of the bone over the calcaneum here, and it impinges over the tendo Achilles, and between this bone and tendo Achilles is a bursa which gets inflamed and it causes a lot of pain. As you can see in this X-ray, where usually we see this extra growth of the bone here, we see the osteophyte developing into the tendo Achilles, and in MRI we can visualize very clearly tendocalcaneum. This is tendo Achilles, and this is the bursa over here, and this is the bone which is impinging over this tendon, causing a lot of pain. So previously, like the whole tendon used to be incised, all this bone used to be removed, and the patient had to take rest for at least 3 months, used to have a lot of pain, insufficiency in tendo Achilles. But because of emergence of latest technique, arthroscopy, where we put a scope inside this space we put a scope, we clean everything, bursa and everything is excised, even the additional bone with the help of a burr it is removed, and the patient is given rest for only 3 weeks, and he will be able to carry on his activities by end of 1 month. So especially in this scenario of retrocalcaneal bursitis, ankle arthroscopy has increased the treatment by leap and bounds. So whatever we see in the everybody we like going to the seashore, and when we see water, sky, air, but only the real enjoyment is there in diving, where we see a lot of things inside the sea like corals, fishes, and you can see the tortoise over here. So ankle arthroscopy is a branch of orthopedics which helps us to visualize what is going on within the joint in a very good way, and also to identify the pathology and treat the problem also. So and minimally invasive way and in a very cosmetic way. Ankle and this arthroscopy has extended now into wrist joint, hip joint, and spine discectomies are done by endoscopy techniques. And in near future, arthroscopy is also going to help us in treating cartilage lesions also. And the science and technology is growing year by leaps and bounds. I thank you all for your patient hearing, and I thank you very much, Ajara Hospitals, and I thank the ground staff here who have taken all the pains in conducting these online presentations. If you have any doubts, any concerns, or any questions, I am here to answer you online. Thank you very much.
Thank you very much, sir. It was a very informative session, and that simile at the end of ocean diving and arthroscopy was very much fascinating. There are a few questions that were asked during the session, sir. I'll be asking one by one. Mr. Nikunj Patel asks, in a recurrent acute inflammation and pain in unilateral knee, what are the likely pharmacological and non-pharmacological treatment options?
See, any inflammation in the knee joint is because of various conditions. Like if you ask me, broadly we classify into inflammatory and non-inflammatory. Inflammatory, when it comes, it is because of any infections or rheumatoid problems or various type of Rh negative kind of diseases. And as I have told, inflammation can also be because of any loose bodies or meniscal lesions if any counter irritants are put over it. So generally, when the patient comes with inflammation of the joint, we basically ask for an X-ray. We examine the joint. Usually, how is the feel of the joint? Increased local rise of temperature will always give us a hint of a infection, and we carry out certain laboratory procedures like CBP, ESR, RA factors, and sometimes ASOT, serum uric acid, and in this way we will be. And if there is effusion, we take the synovial fluid, we aspirate it, and we send it for different cultures and serological examination. And we start the patients based on that. If it is an infection, we start in on antibiotics. If it is non-infective lesion, we start on various rheumatology drugs. And the most common drugs that we have in our armamentarium is NSAIDs. And people who have any problem with NSAIDs like asthma or any kind of edema due to NSAIDs, we put them on steroid. We put them on morphine analogs like Ultracet, and that is tramadol or fluperitin, and something like Kemerol 4, that is trypsin, and chymotrypsin. We put a short dose of steroids, especially in inflammatory joints, non-infective inflammatory joints, and we tend to use hydroxychloroquines, methotrexates to see how the joint is improving. And one more most important thing is inflammation can also be due to abnormal growth of synovium because of various conditions such as that is pigmented villonodular synovitis. When we aspirate the joint, we see a reddish color of fluid, and there are conditions known as osteochondritis dissecans and multiple cartilage forming lesions inside the knee joint, where we can identify with the help of an MRI, or if in spite of doing all these things, if the pain is not improving, then the best thing is to go and scope the joint and find out the pathology, take the biopsy, And if there are any such synovial pathology also, it can be debraided, burred, and that specific treatment can be provided to the patient.
Okay, thank you, sir. Please ask your questions in the chat box, and sir will be answering one after the other. And another question from Mukaddam Sali. He's asking, what are the possible complications of arthroscopic procedures?
Possible complications, very rarely, very rare complications are there. Most important complications I tell to my patient is sometimes the instrument, suppose if you are removing a loose body or when we are repairing certain things, some small part of the instrument can be left inside, very rarely, but also that can also be removed. And infection is one of the complications, but it is very rare because we are always cleaning the joint with the help of a saline. There is part specific complications that we keep in mind, that sometimes a patient can develop brachial palsy, sometimes brachial plexus palsy, because when we are doing shoulder arthroscopy, we put a traction, and sometimes if it is more, then it may cause some kind of numbness or radiculopathy. And sometimes in knee joint, when we are using tourniquet for a long time, it may cause some problems, and we are very careful in maintaining the tourniquet time. And there are in elbow arthroscopy, a lot of important structures are there surrounding the elbow joint, that is nerves and vessels are there. But usually we are very careful to maintain to see that those are not anyway damaged. So overall, if you see, arthroscopy has very least complications, provided it is done in the expert's hand.
Okay.
So very less complications.
Okay, sir. Another question, in acute cases, like in case of emergencies related to the joints, and if the healthcare facility is far away from the actual tertiary centers or so, if the patient is in rural area, what are the likely management options to be given until the transit or until the tertiary care was
So you mean to say that some trauma has happened in village and how it can be shifted to the hospital or point of management, right?
Yes, sir.
Yes. So most important thing is not to get tensed. So if you have any, most of the times it happens in our own residence, like elderly age group slips and falls in the bathroom, or you while climbing down the stairs, your foot gets suddenly sprained, or you get hurt here and there. So best thing, first thing is that to apply ice packs or to apply a water soaked kind of a cloth over the joint, not to rub it with an ointment or anything like that. That can predispose to more inflammation and a possibility of infection. So, and second point is, if there is any fractures anywhere, to control the stabilize the fracture, basic thing you can use is a nearby cardboard. If you have a cardboard, most of the people have cardboard, or you have a broom, or you have anything which gives stability to the joint, can be put over the bone, and it can be bandage can be applied over it till he shifted to a nearing place. And most important thing is not to apply any kind of irritants over the wound. And immediately you can call an ambulance and you can shift the patient, or you can go to a first aid, take a painkiller injection, then you can come to the hospital. And in case of an open wounds, it's very important to apply any kind of antiseptic, to take a TT injection, and to come to the nearest possible center for appropriate treatment.
Okay, thank you, sir. What are the contraindications of arthroscopy?
Arthroscopy is contraindicated in badly arthrosed joint, fibrosed joint, where we cannot even flex the joint. In this way, we cannot even pass an arthroscope inside. Otherwise, there is no such contraindications for an arthroscope. Even in infected joints, it works very well, not only to visualize the joint, but also to cure the infections. So as such, and also it can be avoided in Charcot joints where because of any loss of sensation into the joint, then arthroscope can be can be contraindicated to some extent. But definitely an arthrofibrotic joint is not an indication for arthroscopy.
Okay, sir. So after arthroscopic procedure, what are the restrictions or what are the precautions that are supposed to be taken by the patient?
And one more contraindication I remember is, see, to visualize anything into the joint, we require a good capsule, joint capsule. In any condition where the capsule is affected, like in a posterior dislocation of the knee, we cannot arthroscope immediately, or we have to wait at least for 2 weeks to 3 weeks before putting the scope in. And also the joint should be silent joint, where the initial inflammatory phase has come down. So what was your other question, Dr. Nadeem? What was your other question?
After arthroscopic procedure, what are the restrictions or what are the precautions the patient is supposed to take?
See, wherever a scope is used to do a biopsy or to clean the joint or to remove any loose bodies or to release capsule of the shoulder in adhesive capsulitis or to relieve any stiffness in any joint, there is no need of any rest. A patient can start moving his joint within 6 hours after the surgery, can walk. But wherever a scopy procedure is used to repair the joint, repair of the joint is something that takes, the soft tissue takes time to heal. So when, like in an example, like I have presented a case of ACL with meniscus repair. So in ACL repair, what we do is we use implants here to stabilize the joint, to stabilize the tissues inside the joint with the help of a special implant. So by the time the tissue is well grown within the bone bed, certain restrictions are imposed on the patient, like partial weight bearing for 3 weeks, total weight bearing may take up to 8 to 12 weeks. And higher end activities like going back to sports may take up to 6 to 9 months. So based on the different pathologies and different conditions, we follow certain protocols. So whenever we are repairing a joint, like if you say Bankart stair also, we advise patient to follow a certain protocol with a 3 weeks of duration in between, say up to maximum 12 weeks, so that he not only regains complete movement of the joint, but there is no chance of any instability or any breakage in the implant or all these things. So once the tissue has healed very well, then we can mobilize it. But most of the procedures for inflammation, that is infection or any biopsy or any removal of loose body or debridement, the patient can start moving his joint from day one.
Okay, thank you, sir. Navina Patel asks about the cost factor that's involved with these procedures.
Cost factor of these procedures, yes, as this is a very sophisticated kind of a technology where lots of such fine instruments, everything are used. The most of the cost for this is in form of implants. Those are, most of them are very much fragile with, most of these things are imported. And the most of the cost, I can say 50 to 60% cost of the surgery is for implants and instrumentations. Rest of the cost is like any other orthopedic operative procedure charges. So implants tend to be on the higher side in arthroscopy.
Okay. So what are the general success rates of arthroscopic procedures?
Arthroscopy procedure, I can say it is almost, I say to the patient, it is like 75% surgery and 25% is a protocol always. So why protocol is important means I already have told you that with the help of a arthroscopy, we should be able to fix any pathology, pinpoint, bullshot. It's not like a open procedure where we are not sure sometimes to see these small bones, small things with the naked eye. Whereas in arthroscope, we can pinpoint the pathology, treat it there and fix that there. So coming to the arthroscopy, we should be able to fix maximum 100% there. But after the surgery, the protocol matters a lot. When the patient follows the right protocol, right physiotherapy, and right care, then the success will up to be 99%.
Okay, sir. Thank you. I think last question. How much time does it take for the joint to get repaired completely after the surgery? I think sir has answered this question earlier.
Any joint that is repaired, arthroscopy protocol will be there. Just like if you have a bone fracture, we fix it with rods and plates. So in the same way here, certain protocols are followed when we repair the joint. It basically ranges from 3 weeks to up to 12 weeks based on the pathology, based on what we are repairing, what we are doing. So it differs from disease to disease, joint to joint. Okay.
Okay. So one question is this procedure, is arthroscopy useful in tumors and all, joint related any sort of malignancies?
Yes, I have told you that arthroscopy is growing year by year. There are certain tumors like within the joint. If there is any small cartilage tumors, it can always, if it is benign within the joint, yes, it can be taken care. But something out of the joint, it requires an open procedure. And if the tumor is malignant or it has involved most of the joint, then it is better to go open procedure only. But there are certain tumors that I've already told you in the knee joint or in the joint like pigmented villonodular synovitis, or there is a condition where a lot of cartilaginous loose bodies form, or there are certain conditions known as osteochondritis dissecans. This is a cartilage pathology where it can be dealt with a arthroscopy.
Okay, sir. Thank you very much. One question from Mr. Chandan was, what's the role of a clinical pharmacist in arthroscopy? I think for this question, the role of clinical pharmacist comes at the time of pharmacological intervention, pre and post arthroscopic procedures during acute hospital care. So I think that's the end of the question answer session, sir. It was a wonderful session. Yeah. Thank you very much. And for all the participants, kindly give give your feedback regarding today's session, and your feedback actually helps us to become better. We come better prepared for the next time, as well as this form will be useful for us to prepare your e-certificates of participation as well. The e-certificates of participation will be sent to only the participants who submitted their feedback. And as you all know, Ajara Hospitals conduct these clinical webinars twice a month, on second Saturday as well as on the fourth Saturday from 6 p.m. to 7 p.m. Our next webinar will be on the occasion of World Heart Day. World Heart Day is celebrated on 29th of September every year, and this year, on occasion of the World Heart Day, we'll be having the webinar a week earlier. We'll be having the webinar on 24th of September by Dr. Mallikarjun Rao sir, our consultant interventional cardiologist. And as you know, the theme of this year's Heart Day is use heart for every heart. So probably the topic will be decided within a couple of days, and we'll inform you. For all the updates, join the group, and we'll be posting everything regarding these webinars. And thank you very much. We'll see you in the next webinar. Thank you, sir.
Thank you. Thank you very much. Thank you.